While everyone else continues to filter in, we will go ahead and begin this evening. First and foremost, thank you for joining us. My name is Dr. Rachel Earls. I am a medical science liaison with Myriad Genetics, the makers of the GeneSight test, and I will be your moderator for this evening. One thing that I think is really important before we dive into the topic is during this session, feel free to ask questions. We will do our best to address all the questions that we can. If we don't get to your questions during the webinar, we will make sure to follow up with you after and get you the answers that you're looking for. In order to ask a question, you can put it in the Q&A feature, not the chat, and you have the options to ask the questions anonymously. So please ask us your questions. We will do our best to answer them. And again, thank you for joining us tonight. So we know there is often a strong connection between addiction and mental illness. Depression and anxiety may be the root cause of behavioral and substance addictions, and vice versa. And primary care clinicians have multiple touch points at which to address their patient's mental health, whether that would be when a patient is first struggling or when the patient reaches out for help proactively, or potentially when the issues have escalated and spun into self-medicating or other substance abuse issues. Every clinician would choose the first opportunity to treat their patients and hopefully avoid the second and third instance. Underlying mental health conditions should be treated for patients suffering with addiction disorders to improve the overall mental health of the patient. Yet patients may not be willing to disclose their mental health or addiction concerns. And we know that not addressing the patient's underlying depression may potentially lead them to spiral even further out of control. So this GeneSight Cares webinar seeks to educate and inform clinicians that using the GeneSight test as a tool with the treatment of depression and anxiety in co-occurrence with addiction may lead to better outcomes. This conversation comes at an important time of the year when drug and alcohol dependency, seasonal depression, and stress may be at an all-time high for many people in many walks of life. So what do we hope to gain from this webinar? A lot, but specifically a few things we want to make sure to address. There are tactics to identify underlying depression and signs of addiction disorder. We hope that you can leave this webinar with strategies to help identify patients for GeneSight testing, and then learn how GeneSight testing may be incorporated when trying to treat underlying depression. So the reason you all are here to hear from our fantastic group of panelists, I'm going to go ahead and start off with some introductions. I'm excited to introduce Dr. Walsh. She is a psychiatric nurse practitioner, a certified addiction specialist educator, and a leader who has built her academic career on a strong foundation of innovation, developing accessible and inventive education to enhance the nursing care of vulnerable populations. Dr. Walsh, thank you so much for being here tonight. We're honored to have you. Our next presenter is Dawn Johnson, a psychiatric and mental health nurse practitioner affiliated with the Indiana Center for Recovery in South Bend, Indiana. Thank you for joining us, Dawn.
Thank you.
And then we have Cassie Turner, a psychiatric mental health nurse practitioner with over 13 years of experience in different capacities within mental health. Cassie's affiliated with the Integrated Psychiatric Consultants in Maryland Heights, Missouri. Welcome to the panel, Cassie.
Thank you. It's good to be here.
So before we dive into the discussion, I would be honored to introduce a special guest that we have on the panel, Caitlin Harden. She joins us from Dallas, Georgia, to share her incredible journey and story as a patient with addiction disorder, to then transitioning to become the owner of an intensive outpatient program and partial hospitalization program that just opened its second entity, which acts as a continuum of care for people who go through residential treatment programs and need medication management once they complete that program. Welcome, Caitlin, and we're going to start with you this evening. We're so happy to have you. Would you mind telling us a little bit about your personal experience with addiction?
Yeah, absolutely. So grateful to be here and to have this opportunity. My name is Caitlin Harden. I'm a person in long-term recovery. For me, that looks like I have not used a mood or mind-altering substance since February 28th, 2016. So I'm going to try to sum up my story as much as I can, because obviously, there's a lot of pieces that go into it. But just starting out from like my childhood experience, I had a lot of manifestations of addiction or, maladaptive coping mechanisms that were a result of CPTSD, which I didn't know at the time, but later found out as an adult. I had absent mother due to substance use disorder, and a single father that was building a career. So as you can tell, that's pretty difficult being a single parent and, doing those two things together. Some of the behaviors I showed as a kid were manipulation, defiance. I even acted out in some disordered eating. I skipped school, which was, odd for me because I always enjoyed school and accelerated in school. And due to a variance of barriers, I didn't receive mental health treatment or any help in that area, which I probably needed at that time. Transitioning into my adulthood as a teenager, I think I first used any mood or mind altering substances at 14. And it started off what we would consider kind of light, marijuana, alcohol, stuff that's more used recreationally and amongst, kids today. And then once I hit age 16, I started to experiment with harder drugs. So cocaine, benzodiazepines, just kind of whatever I was exposed to at the time. At age 17, I got pregnant with my now oldest daughter, who is 10. So obviously that gave me a new barrier, which was continuing school and getting my education. Being a teenage mother was another huge, step for me in life. But it came with its own set of problems. Once I got a little bit older, her dad and I split in around when she was around 1 year old. So I think I was 19. And at age 20 is when I first was introduced to heroin. And that was really the spiraling point of my addiction. Once I was exposed to heroin, it was a pretty quick decline for me and a speeding of my addiction. I got sober at age 21, and that was due to an overdose that I experienced, where I went into cardiac arrest. It was a very traumatic experience for me, but it also was the eye-opener that I needed to get some help, not just to me, but to my family as well, because growing up as a master manipulator, it was pretty easy for me to try to cover things up and make things appear to be okay when they weren't. So once that experience happened for me, I went to treatment, which was very difficult for my family to figure out and navigate. I ended up at a facility that we in the field consider a flop house. So there were people using drugs while I was there. There wasn't a lot of supervision or accountability. But somehow I remained sober. And that was actually a huge driving force into why I wanted to start working in the field later on. So I stayed sober. I began working in the field in 2018 at a residential treatment center, Blue Ridge Mountain Recovery Center. And that's where I really kickstarted my career. I got my education in certified addiction counseling. So I went through those courses, just really soaked up all of the knowledge that everyone had to offer during that time. I ended up having 2 more children. So I have 3 children total. My 10-year-old, I regained custody of her. And in 2020, I opened my first facility. So I opened Hope Harbor in August of 2020 while I was 7 months pregnant, which is an outpatient program for substance use disorder. And we just opened our mental health track in October. Then I opened Iris Wellness Group in Chattanooga, Tennessee, which is substance abuse and mental health primary with a mental health adolescent program. And in June of this year, we opened up Restoration Hope, and that is a mental health clinic that we developed as a continuum of care, because a big noticeable issue that we were seeing if clients were contacting us due to a relapse was, 2 major components. The first was I stopped taking my meds. So they stopped, going to their appointments or didn't follow through with aftercare. And the second was that they didn't, continue attending their self-help groups. Self-help groups, really dive into some of the key focuses that address behavioral issues. And So we decided to develop that so we could continue seeing patients after they discharge and hopefully support them with their psychiatric issues after discharge. But addiction, I would say, is almost, if not entirely, always coupled with a co-occurring disorder. So if you have untreated mental health issues, it's going to amplify the pre-existing or existing symptoms of addiction when they're left untreated.
Wow. Thank you for sharing your story. That was, for lack of a better word, incredibly moving and impactful. So I really appreciate your vulnerability and your openness and candor. I think it's incredibly important to have these conversations, and you hit on so many important points, one of which I just wrote down because I think it is so profoundly important. The need to support co-occurring mental health conditions. Untreated mental health conditions can amplify these pre-existing addiction symptoms and addiction behaviors. And so I really appreciate you bringing up that point. And again, thank you for sharing your story. With that in mind, I'm going to turn the conversation to Dr. Walsh and ask, as the owner and founder of a recovery center yourself, do you see similar trends in your patients and in terms of mental illnesses like depression kind of being at the root or being associated with these addictive behaviors as well?
Oh, absolutely. So when I started my career, I'm a family nurse practitioner. I worked in addiction treatment as a family nurse practitioner, and I quickly saw that there was more to what I was seeing in my addiction clients than just addiction. And I wanted to be able to give them the best care. And as a family nurse practitioner, we get taught, primary care, we get very little mental health. We don't even have a rotation that is related specifically to mental health like you do in nursing school when you're pre-licensure. So, I did know a little bit about it because I'd been working in the field as an addiction counselor for over 30 years prior to becoming a nurse. So I did have personal experience from that view, but not the medical and clinical experience. So I went back to school to get my Psych NP so that I could better care for the addiction patients that I was seeing with the heavy co-occurring disorders.
Thank you for sharing that. I'll turn it over to Dawn. So Dawn, if this is what's mirroring or what you're seeing in your practice, my question to you is a bit more of a practical question, is how do you get this information in the first place from your patients? How do you realize these co-occurring conditions are happening? Do you feel like patients will open up about their mental health struggles or addiction, or do you feel like you kind of have to look for certain signs when you're having those conversations?
So it's interesting, Dr. Walsh. I actually did it the opposite. I actually lost my husband to complications of his mental health and addiction issues in 2013, went back to school then to do human medicine and got my Psych NP first. So I've been doing psych and addictions from day one with my Psych NP. And then I went back to school to get my family practice because I was just getting exhausted and thinking, yeah. So doing my clinical rotations in family practice was really interesting because patients would come in and they'd be obese and hypertension and diabetes, and they'd be wanting, med adjustments, just keep coming back. And of course, my Psych NP mind, some of the first intakes, I'm doing the questionnaire, and my first thought is, well, tell me about your childhood trauma, which is not appropriate in that setting, because then this patient starts crying and says, well, I've never told anybody about my childhood trauma. How do you even know? Well, you have all these underlying chronic issues, and, clearly you're not taking good care of yourself. You have all these physical issues. There's probably some underlying mental health issue there that needs to be addressed. So, you start asking those questions, and I swear, I really believe that working in primary care for the amount of time that I did, 90%, I don't know, Dr. Walsh, 90% of chronic, physical chronic disease there's an underlying mental health issue there. So, you ask those questions in the beginning. We've got those PHQ-9s, we've got the GAD-7. We can ask about, do you feel safe in your home, childhood trauma. I asking about alcohol and drug use, how many glasses of wine do you have at night? A lot of times people say they're drinking it to sleep. I've been amazed at the amount of older providers who have said, yeah, have your glass of wine or two for sleep. Well, you're not going to get a good solid sleep with that. So it's just asking those questions, but I know in that primary care setting, you're limited on that time. So, but yeah, I mean, just asking those key questions as quickly as possible. And in my setting now, I'm back to it's dual diagnosis, detox addictions, and we do have a primary mental health floor. But so those patients, it's a given, they're coming into detox. And again, Caitlin, your story, amazing. Congratulations. That's wonderful. And that's the reason why we're doing it. For that hope. She's creating now a space for hope for people that were just like her, and she can show them that it can be done. So well done. Yeah. Hope that answers the question.
Yes, it did. And it brought up a lot of other points as well. So it really is interesting when you think about your trajectory through your career, because as you started as a psychiatric mental health nurse practitioner, you mentioned that you were more prone to ask those behavioral questions, but maybe not all family medicine clinicians are, because they don't start with that psychiatric training. So that, I think, is something really tangible that people can take away from this. Is I know family practice has a incredibly, a big list of things to get through in a short amount of time, but implementing those screeners like GAD-7 and PHQ-9 can be incredibly beneficial, especially when I feel like you do ask patients those questions about how are you feeling, tell me about your childhood. Those things can be very stigmatizing. So I want to turn it to Dr. Walsh again. So have you experienced any reluctancy from patients to share their mental health struggles due to stigma or other reasons, perhaps?
Oh, absolutely. And, I feel like I build a good rapport with my clients pretty quickly, but because of their own even self-stigma, right, from what they have gotten from the world, right, from their families and generationally and even socially, right, the stigma that they've experienced, and then the self-stigma. And, it's been so interesting to me in talking to patients about, Dawn brought up, about the adverse childhood experiences. Adverse childhood experiences impact, patients' health, in 90%, right? I would even argue 95%. Mm-hmm. And so in talking to clients and trying to, get some information, like tell me a little bit more about your background so we can get a good clinical picture of, was there a family history of depression, this, that, and the other, then that's where you hear the reluctancy or the stigma, like, oh no, that happens to everybody, or, that my parents didn't talk about that. We didn't talk about mental illness. And that's when it makes it really challenging and really hard when you have people that say, my family would not talk about mental health. We had this aunt so-and-so, we used to say crazy aunt so-and-so, but I don't really know what crazy aunt so-and-so had, so it's really hard to pinpoint. So many times, the mental health, the underlying mental health issue just kind of gets skimmed over because they're reluctant to talk about it, and because of the stigma.
Yeah. And I think too, from my personal experience, this is a party of one here. I did have a primary care doctor ask about childhood trauma. And to me, trauma is a relative word. It means something different to everyone. So when I hear trauma, I may think one thing and someone may think something completely different. So I think it's important to clarify what actually is trauma. It may not be the extreme example that you're thinking of in your head. You can have, reoccurring mild traumas that have an effect on you over time. So I think that's really important. I'm itching to turn it over to Cassie, who we haven't had a chance to speak with yet. So to follow up, Cassie, what are some ways that you think clinicians can get information out of patients who may be reluctant to share? And furthermore, are there signs of depression or anxiety that you can look for if patients are not as willing to share?
Yeah, definitely. So one thing I do want to touch on real quick, actually, so the different stigmas were mentioned. There is also a stigma with providers, not to slam any of the providers in here, but, people do unfortunately look at people differently, I feel like, with addiction, with underlying substance use disorder. And sometimes those are just the patient's perception. And sometimes like they do encounter kind of negative reactions, just, even within, sometimes I feel like mental health workers, like, oh, they're just an addict, or, so that definitely is something to keep in mind, that, a lot of times these patients have had negative experiences too. But one of the big things, and I think someone else mentioned this, is just trying to establish rapport with our patients, really being supportive, non-judgmental. And sometimes some of this may take a little bit of time. You may have to kind of slowly work away on this and kind of work with them. I kind of always joke that sometimes interacting with some individuals, it's kind of like a dance. You need to know kind of when to push and when to kind of pull back. And sometimes you just kind of learn that with time. Another good thing to kind of keep in mind is motivational interviewing. We could do a whole training just on that. So if you're not familiar with that, I definitely would recommend checking it out. I mean, that can be utilized, with patients with underlying substance use disorder, or even some of the chronic medical conditions and kind of lifestyle changes. One good place to check out is, and hopefully it's okay to give out some resources, pcssnow.org. But if you Google motivational interviewing, that's one of the first things that comes up. There's one specifically, principles of motivational interviewing useful for PCPs. And they have a ton of other resources. They're free and you can get continuing education. So I definitely think it's worth checking out if you're not familiar with that. And then other things that you can look for, I think a big thing as far as like signs of underlying mental illness is looking at those nonverbal signs and cues. So kind of a flat, blunted affect, not smiling, not very expressive, slow responses and gestures, or on the flip side, even, speaking rapidly, pacing around, poor eye contact, being very fidgety, wringing hands, clenching fists, being irritable on edge, appearing very disheveled or inappropriate dress. So like wearing a winter coat in the middle of summer,
Right.
poor focus. I mean, I could go on and on, but yeah. And then
Those
of
are-
course the screening tools, as was previously mentioned. So the G87, PHQ-9.
Those are incredibly helpful tips. Thank you. And they're very tangible. So I appreciate you sharing them to the audience. We have gotten a couple questions. One I'm going to send to Caitlin. It says, I hear the phrase mood and mind altering substances frequently stated by those in recovery, referencing sobriety from illicit substances. Could this phrase unintentionally cause resistance to mental health meds, which are also considered mood altering substances in a sense?
So it really depends on who you talk to, I think. Of course, there's always going to be people that are opinionated, whether it be for their own experience or, what they've been taught. But I know for me personally, when I speak on mood or mind altering substances, I'm specifically referencing substances that I intentionally used to alter my state of being. There's an intention behind that use, and it's not to, heal myself or to take care of my mind and my body. The intention is a distraction or, whatever else I'm using it for. And I did also want to share on something that Cassie just mentioned when you were talking about the motivational interviewing and everything. I think that there's a huge gap between physicians and then other practitioners, specifically counselors, where there's education that both can benefit from that they lack being told is, a requirement of, their education. I meet doctors that, continue to prescribe mental health medications that do not have a specialty in psychiatry. I've seen many patients come in that continue their psych meds with their PCP, or they are, managing medication assisted treatment. And then on the other end, I experience a lot of practitioners in the substance use field that really lack the knowledge on co-occurring disorders and how pertinent it is for them to receive competent psychiatric care in order to maintain their abstinence when it comes to their substance use disorder. So just wanted to throw that in too.
Thank you for sharing that. I appreciate it. Cassie, we are getting some requests to give that website again. Do you mind sharing that one more time?
Yes, I'm sorry if I was talking too fast. So it is PCSS. P is in Paul, C is in cat, S is in Sam, S is in Sam now. So PCSSnow.org.
Thank you.
And it's the same website that I don't know if anybody, I know the psych people were probably all waivered, but they're the ones that you can get, I think, your waiver training through.
Awesome.
Rachel,
Thank you.
Can I address the question that Caitlin answered?
Yes.
I think it's important. And I think Caitlin makes a really good point. And I really don't think it's the language that Caitlin used as much as it's the stigma that is already in the rooms, right? That have already, I remember when I was 19 years old as an addiction counselor, working with another addiction counselor that I was really, really close to, was a great guy. But because of the stigma that was in and around treatment at that time, he was living with bipolar disorder, and he felt it necessary to come off of his meds because of the stigma that was already prevalent at that time. And he wound up completing suicide. And so that really has been kind of my flag since then, of really educating people. And I've been doing it for many, many years about the difference between, it's okay to take an antidepressant if you have depression. If it's not any different than being diabetic and needing insulin. And so I've had to do a lot of education around that. We are and do have a movement for recovery language, and one of the things is, it's somebody has the right to say and address themselves as however they choose to, right? And explaining what that means. If somebody wants to call themselves an alcoholic or a drug addict, that is okay too, that is their right. And so we're moving towards, and as we're talking about recovery language, there was a period of time when recovery language, they were trying to get away from even using the language alcoholic or drug addict, right? And now they're realizing that there's people that want to identify that way, and that's okay. And so however people want to identify, as Caitlin identifies herself as a person in long-term recovery and explains what that means to her, that is her right and her absolute right to choose how she wants to address herself. So, but that was a really great question. So thanks for that, whoever asked it.
Thank you, guys. And it kind of lends itself to the next question that I was going to talk about, Dr. Walsh, as well. So you are an educator of the next generation of clinicians. That is your one of your main jobs. And so one question that I had is, are there any changes that you're seeing in, ways you're educating the next generation of practitioners in terms of how to identify these underlying depression, addiction, disorders? So you mentioned that you're changing language. You mentioned, we're kind of having transitions there. Are there any other tools that you feel like are really significant for the up and coming generation to help with the treatment of these co-occurring conditions?
Yeah. And, I don't think I'm the only one, but, it's something that I'm very passionate about, working, all these years with patients, living with substance use disorders and hearing and seeing how they were treated. Even as a floor nurse, I remember my very first clinical experience as a student nurse. And I was so excited, right? Because I'm taking care of this guy that's there for alcohol withdrawal. And so I'm talking to him, I'm giving him these resources, and I'm telling him how he can find recovery and, and we're connecting and we're having great conversation. And the physician walks in, and I tell the physician, I gave him these resources, and he's gonna use these resources when he leaves here. And he looks at me, and I'm not even gonna tell you what he said, but it absolutely stabbed me in the heart that somebody would talk about another human being in that fashion. And so it was that moment that I decided that I was going to make sure that one day I became an educator and taught all nurses how to treat and take care of patients that live with substance use disorders. And I'm really, really super passionate about that. I love being a clinician. I love taking care of patients individually, but I feel like I have a greater impact on training and educating our next generation on really how to give competent, ethical care to patients that live with substance use disorders, and especially with co-occurring as well. And one of the foundational things that I think is important for students to know is that, and it's been around for a long time, the ACE study done by Kaiser. That study was a longitudinal study. It was the study that nobody knows about. It was done a long time ago. We don't talk about it enough. So we talk about it to our students to let our students know that people experience a high ACE score or adverse childhood experiences, they are very prone for substance use disorder. And my definition of trauma is whatever you tell me your trauma is. So it doesn't matter. And we call it, and I don't even like calling it this, but we call it big T, little t. Trauma is trauma. I say trauma is trauma. And when children experience trauma, they are set up for depression, anxiety, substance use disorder, and so on. So it really is important to give them that foundational understanding about adverse childhood experiences so that they know and understand, so they don't look at this adult like, what's wrong with this person? Why can't this person get it together? No, go in there and find out what is that person's story. What happened to that person? Because that's what we have to get to really help that person.
Thank you. It's so powerful to hear. And I think you bring up so many good points. It's so easy to judge someone who has a different path than you, but you have no idea what got them there. And it's to go in from a point of view of trying to understand rather than judge someone, I think is critical. Dawn, are there any tools that you have found helpful in your clinical practice with when you were treating these mental health or co-occurring addiction conditions?
Yeah, sure. And to lead right in with what Dr. Walsh said, betrayal trauma is a big piece with our patients. So we do our facility is trauma-informed care. And that betrayal trauma, it's when somebody that's supposed to be a caregiver or supposed to have, been a person they could trust is the one that harms them as a child. And many times patients will just kind of push it aside. Oh, I dealt with that. That's not a big deal. That's not why I drink. That's not why I use. And the stigma piece. So I do groups at our facilities as well. And the lovely thing about ICFR is we actually do hire back our patients. We do peer recovery type training. And then, so basically my colleagues are former patients that now are kind of like Caitlin, are just building on it. They're the most resilient, most intelligent people you'll ever meet. But kind of like what Dr. Walsh was saying, if you go to, and I told the patients this, I'm like, if you go to a family reunion and you're obese and you're fatigued and you're sick and they see you and you don't look well, and the next year you go to the family reunion, you've lost weight, you look better, you're feeling better, what happened? Your family members, what happened? Oh, I went to the doctor, I found out I was diabetic and I'm taking insulin now and I'm feeling great and I'm getting my health back. Like, now you go to a family reunion and you're bipolar and you're in a manic episode and you're batshit crazy at the family reunion and everybody's talking about you and everybody's making fun of you. And then you go back next year and you're well rested, you're calm, you're at peace, you're interacting with your family members again. And they say, what happened? And you say, I found out I was bipolar. And all this time, and I got the GeneSight test and I got on the right medications and I'm feeling great. And that is my dream. My dream is that we don't treat this any differently than we treat any other chronic disease, hypertension, thyroid, diabetes. where we've been lacking is getting the right medications for the patients. And so they've been on this roller coaster. And my first clinical experience was with a pediatric psychiatrist. She did only foreign adoptions. So the minute those kids came in the door, she was doing a GeneSight test. She's like, I can't ask the mom, did you do well on Zoloft? You know, I have no history on these patients. The minute they walk in the door, because I can't risk, you know, the ups and downs of trying to figure out what med to start this patient out on. So, you know, and I say it all the time with our patients that come in for detox and recovery. One, they're going to say to me, I don't want them to take a pill to make me feel better. That's always the number one thing they say. And of course, I remind them what they've been self-medicating, but I use the GeneSight then as a tool to say, listen, let's learn everything we can learn about you. Let's learn everything we can learn about your body and your mind. Let's get your lab work back. This is how your enzyme systems work. This is how you metabolize medications. Let's pick something that's going to work well for you. And so they start building trust because they're not a guinea pig. That's always what they say. I'm not going to be a guinea pig. Okay, let's do that GeneSight first. And the turnaround time is so quick with the GeneSight test. And, you know, and I'll send them to their room and say, pull up YouTube and look at your guys' 2-minute video on explaining what the GeneSight is. And I just want them to get as much information. If I have them for 5 days or 30 days, I want them to get as much information about their body. And then I also have them use the GeneSight as a tool to like write down, what have I been on in the past? How did I react to it? You know, and my bipolar patients also keep a journal. Is there a cycle to, you know, your episodes? So it's just another tool for them to use. But yeah, you meet them with every tool you can possibly meet them with, because you may only have them for 2-3 days in my case, or inpatient, you know, or outpatient, you know, you may only have them for 30 minutes, but how much hope can we give them in that 30 minutes to get them excited? And a lot of times the patients feel like it's Christmas when they get their GeneSight back. I mean, I know I did. They're just excited to learn about themselves and see that there's another tool and another way that they can start taking better care of themselves and understand themselves more clearly. And typically they'll go through that GeneSight and be like, well, no wonder this medication screwed me up, you know? So yeah.
Thank you, Dawn. I will take a second. I don't know if everyone on this call knows what the GeneSight test is, so I'm just going to give a brief overview for those who may not know. So the GeneSight test is a genetic test that tells you information about how your patient's genes may affect their response to psychotropic medications. And so the GeneSight test will categorize medications into different categories based on the expected impact your patient's genes may have on medication response and metabolism. We've gotten quite a few questions about the GeneSight test, so I want to address a couple of them out the gate. So the first question is, it is my understanding that the GeneSight test provides information about metabolism, not efficacy. Metabolism data may provide information about dosage adjustment and or the likelihood of the patient experiencing side effects. That being said, as psychiatrists frequently prescribe medications and monitor for side effects and then make adjustments as needed. So GeneSight looks at 2 different types of genes. First type of genes are called pharmacokinetic genes. Those are your metabolism genes. So to the person who asked that question, you are 100% correct. We can provide information about metabolism and potential suggestions for dose adjustments. So that is correct. But we also look at another type of genes called pharmacodynamic genes. Those genes provide information on likelihood of response or risk of potential side effects. So we do provide kind of 2 separate pieces of information there for all of the medications on our report. The next question I hear that I got related to this is, do any of you, so this open to the floor, do any of you have experience in dealing, we'll bring this full circle, dealing with stigma in specific populations? So in Black communities across the country, there's often a stigma about mental health disorders, let alone acknowledging the need for behavioral or pharmacotherapy. Combine that, cultural factors combined with pharmacogenetic variations to medication metabolism may result in poor outcomes. So I think the general question here is, have you had experience with stigma and or stigma related to the GeneSight test when utilizing it with patients?
Yes, I feel like Dr. Walsh is probably, you deal with a lot of different populations. I have myself, but I don't know if Dr. Walsh wants to.
Yeah, I mean, I was going to give other people a chance to talk, but absolutely. I mean, I see, stigma with not only taking medications, but even GeneSight. So I have to really do a lot of education, and I'm going to kind of bring it back to what Dawn said about mentioning about, what did your mother take, and that's how I was trained, right? You would find out what the family member took. If a family member was diagnosed with depression and they were successful on one medication, then you would likely prescribe that medication because you would think that that person had the same genetic makeup and they would do well on that. Well, that is not the case that I've seen. I've seen mother-daughter with two totally different genetic profiles. And so that is the story that I usually use to help. In this case, when somebody has, I don't think that will really help. And then, if somebody is even reluctant to use any kind of medication, let's do the GeneSight test first and at least take a look at what your profile looks like, so we're not guessing, so that you don't have to go through, you don't have to be the guinea pig or the experimental person that we're going through 5, 6, 9 different medications, which I've seen many times with patients coming to me that have been through treatment multiple times, and partially because they've had an underlying mental health diagnosis that was not well treated, and they go to a provider that keeps prescribing them medications after medications after medications, even increasing medications when they're telling them this doesn't feel good, I'm having these side effects. They're saying, well, we need to go up. That's not likely. I don't really ever hear that. All these different stories that I'm hearing from the same patient, from doctor after doctor after doctor. And then we do the GeneSight test, and it turns out that every single medication that she tried to tell a provider that she had issues with was on this GeneSight test as her being a poor metabolizer or having some kind of, adverse effect of the medication, and the GeneSight test showing that. And she cried. When we got her GeneSight test back, she cried. And we were able to get her on the right medication. And coincidentally, 2 medications, she was on 9 that she had never been on.
Wow.
Wow.
That's very powerful. Thank you for sharing that. I want to turn it over to Cassie. So I
I'm
think
good timing, because I was going to add something about the question, but you go
then
first.
go right ahead, and then I'll ask after that.
Sorry. So I was just going to touch on, so I know with the other part of the question, stigma, particularly with the different cultures, was mentioned, specifically the African American community culture. So I've experienced a lot in the past that definitely there is kind of another layer of, stigma there, we don't talk about that, like, it's all kept in the family, or, you pray it away. And so kind of stigma from the family, and really a lot of times a lot more resistance to medication. And so one of the big things I think is kind of bringing it back to, I think both of you guys have kind of touched on it, but it's another medical condition. So it's not different from diabetes, hypertension, there's neurochemical differences in your brain. And so medication and therapy may be necessary.
Absolutely. I think it has come up almost every GeneSight Cares webinar that I have done, that how people have come to the conclusion that mental health conditions are diseases of the mind, not the brain. The brain is the most complicated organ that we have. We don't fully understand it, and we know that there are neurochemical imbalances associated with these. This is a very innate biological condition, but sometimes it's just not perceived that way. It's perceived as something that we have more control over than we do. So thank you for pointing that out. My question for you, Cassie, is, so we've talked about what the GeneSight test is, talked about how it could potentially add value, but what convinced you as a healthcare provider to actually offer the GeneSight test? What made you say, this is something that I actually want to use? And then how has that had an effect in your practice?
So before 5 years ago, I honestly had no experience with it. Most of what I had been doing was inpatient, and then an IOP at a hospital that was primarily mental health, but also some substance use disorder, but they just didn't use it there. And so at my last job, it was a unique program. And one of the largest components of my role was we basically worked as consultants for pediatricians. So they were trained on how to treat some of the most common types of mental health conditions. And basically, they kind of came to us when they got stuck. And so we would help guide them, and they were the ones that were still managing the care. And so the psychiatrist and the director of the program was amazing, and he used it all of the time. And he had actually worked with a lot of pediatricians in rural areas, and he had actually like turned them on to the wonders of GeneSight. And so I learned really everything from him. And it's just, yeah, phenomenal how much of a difference it can make. And so we use it quite a bit there. And then I've continued to use it in my current role. So yeah, and I think it's especially beneficial in those with substance use disorder, because, you know, there's obviously poor outcomes and a lot of risk of leaving mental illness untreated or undertreated, you know, including to the extreme of suicidal ideations and some of those more severe symptoms. But those with substance use disorder, that puts them at risk of, you know, if they have stopped using, return to use, and all of those added medical risk. And then depending upon the substance, and I mean, just about everything these days is laced with fentanyl, so even possibly death. So it's especially important. Another big piece, I think, again, with those with substance use disorder, it's really harder to kind of figure out what's what with the meds, just from the standpoint of oftentimes, you know, they could be taking meds while they're active in their recovery, or not in the recovery, active in their use. And so they're using substances, you know, poor compliance with the meds. And so you really can't determine, was it that the med wasn't helping, or was it that you were still using? And so it can just be another tool with that.
Thank you for sharing. It lends itself really nicely to another question that we've gotten in the chat, specific to the GeneSight test. So I'll open this up to the floor again. The specific question, and I'll kind of follow up with it, is, do you still have to fail therapeutically on 3 antidepressants before running the GeneSight test? So the answer to that globally is no, but I will kind of let the professionals answer in terms of when do you use GeneSight? And then we can kind of go a little bit more details into coverage questions if those come up. But to anyone who is willing to answer, when do you bring GeneSight on board?
Honestly, I do it the minute they walk in the door. I just do. I mean, having a spouse who was a patient that didn't get the right care, and even being a patient myself after his passing, you know, I mean, it's sacred space. You're going into somebody's trauma, you're going into somebody's mental health. You do everything you can possibly do to do it right from the beginning. And, you know, every tool I have, I'm gonna use every tool I have. So I use it right from the start.
Okay.
Yep. And I will say, when I first started it, you know, I've been using GeneSight for a long time. When I first started using GeneSight, if a patient came in and told me that they had failed on 2 medications, I would recommend GeneSight. To now, when people walk in the door, the first thing I do is recommend GeneSight. And I have patients that come to me even that say, I had this medication, I wound up in a psychiatric hospital after taking this medication because I had such bad suicidal ideations. It was terrible. Now my PCP is recommending this medication, and I read the side effects and I'm scared to death to even take it. What do you recommend? And the first thing I recommend is, let's do GeneSight.
Okay, so there's a few perspectives here that I also like to provide. So clinically, what does the data show? So we have the strongest clinical evidence to support the utility of GeneSight after 1 medication failure. I am not a member of the sales team, but I will, for the person who asked that, I will make sure that the sales colleague in your territory connects with you after this, because I know there are differences amongst different covering entities in terms of their requirements. Some require no medication failure, some require 1. So I will make sure that that person connects with you after. Another question we've gotten about GeneSight, and this is definitely something that the panel should answer. As a prescriber, how much office staff support would I need to facilitate the use of GeneSight? So more, I guess, logistics of how do you actually do GeneSight?
So for our inpatient, our lab techs do it. When I was doing more outpatient, I would have the kits in the office and would just do them while the patient was sitting with me. I mean, it takes 30 seconds.
It's
So-
a buccal swab. I
Yeah.
should have mentioned that in my description. I'm sorry about that, but okay.
Yeah, so just do the swab real quick. When I was doing some of my clinical rotations and getting some of the primary care providers I was working with to start using it, just find somebody who's passionate about it in your office, passionate about mental health stuff. They'll jump in and decide they want to do it. I mean, usually if you can grab somebody that you find has more of a, you know, experience with their own mental health issues and it's something that they have an interest in, then designate them to be the one to do it. But yeah, it's easy enough to do. I mean, it really is. And you guys pretty much work it out to have somebody that we can call if we have issues. I mean, you're really good at providing support if we need it. So yeah, if you don't mind, can I go back real quick, the cultural question?
Please.
Cultural humility, I think, is really important. So, you know, we used to use cultural competency, but just cultural humility, being open to listen to what people have to say. But I also, like locally, we have Indiana Minority Health Coalition. I've had several young African-American men that have had some mental health issues that were just a little bit, had some of the same themes with them. And so I would reach out to Indiana Minority Health Coalition. So I'm sure there's probably in different areas, minority health coalitions or people you can reach out to that can kind of help with teaching about the mental health stigma in your area. But definitely that cultural humility. I sat with a Hispanic mother the other day with one of my inpatient kids. She has a real problem with medications. And there's been times where I've been like, fine, you know, we'll use grandma's tea. There's nothing in it that's a problem. And we'll just use this to go along with it. So that's kind of something I'm passionate about, just having that humility and listening to the different cultures.
And I think that's a really good, important way to frame it, that GeneSight is a tool. It is meant to be used in conjunction with all of the other clinical factors that you're already using, including your clinical expertise. It is not an end-all be-all. So it's meant to be used in conjunction with all of the other techniques you're currently using. So I think that was a wonderful way to frame it. Another question I've gotten about GeneSight.
Quickly, Rachel, I just want to say how easy to use GeneSight is. I'm a full-time faculty member at Rosalind Franklin University of Medicine and Sciences in North Chicago. And I practice in Atlanta 1 day a week. And I don't have office staff. I'm it. And I still do GeneSight. I do it myself. It takes 30 seconds to do the swab and 30 seconds to put the order in. That's how easy it is.
And then you FedEx it off.
Yeah.
However,
Drop it off on my way home.
Yeah.
There you go.
So anyway, I just wanted to address how easy it is.
Yes.
No, I think that's very important. We healthcare providers have limited time, so ease of use and ease of access are critical components to something being effective in your practice. So thank you for sharing that. Another question I got is related to cost. How much cost burden would GeneSight be for my patients on Medicare and Medicaid? Does anyone feel comfortable speaking to that? I'm happy to take that one. Go ahead, Cassie.
$0. Medicare, Medicaid.
Yeah, it is covered for Medicare and Medicaid patients. So that's the great news there. I got a question that's related to specific medications on the test. So can this test include information on some of the newer meds, so Spravato, Uvality? So we are always looking to add new medications to the GeneSight report as they become available. They just have to go through kind of a rigorous scientific process to make sure that the genes that we look at actually have an effect on medication response or metabolism. And so if you have questions on specific medications, I recommend that you reach out to our medical information team, and we can tell you why we do or do not include it on our panel if you have specific questions on that. And we will provide afterwards, I should have mentioned this in the beginning, we will provide resources for you in terms of contact points, websites, things of that nature that we will share with you in an email, and that will be one of them.
And Rachel, I think it's important to mention too, the GeneSight promise, the that the most a patient pays is $330.
Yes, that is very
And-
important.
Yeah, and you also have the compassionate care. So there's a lot of avenues when you have a patient who needs it. Don't let cost be anything that deters that.
Somehow it has stumbled upon 7:56 p.m. And so I want to make sure we address one final question, kind of go through the panel. Everyone, please provide their insight. I want to talk about or conclude this conversation talking about a statistic that has come from the National Institute on Drug Abuse, or a statement. And they've stated that treating mental illness like depression, anxiety, post-traumatic stress disorder, ADHD, and others with medications or other therapies is crucial to address the addiction and overdose crisis that now claims over 100,000 lives annually. So starting with Dawn, do you agree with this? And what do you think is one tangible thing clinicians in our audience should take away from this discussion to help treat the underlying mental health conditions in the context of this nationwide addiction and overdose crisis? And then we'll just work our way through the panel.
Yes, I agree with that. I think it's very rarely is the addiction the primary. It's always there's something that led to someone needing to calm their brain down. In which case we need to treat them with the psychotropics, and you have every tool. Have every tool in your possession. The minute you meet that patient, you have to have every tool available to save their lives and impact, like with Caitlin, impact the next generation. Look at how many generations now that she has affected moving forward, her children, their children. It's just huge. So you have everything available when you meet that patient, every tool.
Caitlin, I'll turn it over to you.
I'd have to agree. I think at some point the substance use becomes temporarily primary, and it has to be treated. But once you have begun treating the substance use disorder and they have some time abstinent, then that's when all the underlying issues kind of take precedence. And that's why it's important for practitioners to have that education and to understand how to address those issues once they do start coming up, because they absolutely will.
Cassie? You are on mute. I'm surprised it hasn't happened thus far, the first time.
Sorry.
It's okay.
TMI, I'm at my parents' house because I didn't want to have a toddler and a baby crying and running around in the background. So
no judgment.
So, yes, I agree with everything that's being said. And again, just with the severity and the risk of everything that go along with, substance use disorder and the underlying mental illnesses, as Dawn said, and everyone's saying, like, using every tool that we can and making sure that we're doing what we can to to help patients and in the recovery.
And Dr. Walsh?
So, the first time you meet a patient that has relapsed, you should be asking the question, what else is going on with this patient? So many times I've seen patients that have gone through treatment, so many times, unbelievable amounts of times, and nobody has asked the question. Nobody has looked at what else is going on with that patient. That's one thing. And then the other thing is that we absolutely have to get away from this treatment mindset that if a patient comes to treatment, they have to get off of all of their meds. I can tell you, and we don't have enough time, but a very sad story about a treatment center that I used to work for that made a patient get off of her medications that she had been stable on for a long time. And it was a bad decision. And it was a terrible ending to that event of that person's life, because treatment thinks that we have to be abstinent based, and that's not the case. We have to treat the underlying mental condition.
Thank you doesn't seem sufficient to our panelists and to our participants who have asked questions and engaged, but thank you for having these conversations. Thank you for sharing your knowledge. It is so appreciated. We have so much still to learn, but I think it's great that we started this conversation. For the participants whose questions were not addressed, like I mentioned, we will follow up with you after. We will share resources with you for contact points following this webinar. So sincerely, thank you so much for your time. I know it is precious, and you will be hearing from us soon. So I hope everyone has a wonderful night. Thank you.
Thank you.
you. Thank you, Caitlin.
Mhm.